morning. So I'm going to be talking to you today about the potential of using AI in many different aspects of healthcare, making people healthy. And I'm presenting work that represents the work of many, many people across Google. This is not all my work, but I'm very privileged to present work that we're doing in a broad set of areas. So first, why is now the right time to apply machine learning and AI to problems in healthcare? Second, I'll talk about what are some of the things that we're actually doing in the space. And given what we've been learning, I'd like to share some high-level lessons about things that happen when you do this. So first, why healthcare? I think one of the things that was touched on in the conversation is we've seen real advances in how machine learning can be used to tackle different real-world problems. So for example, in image recognition, we've seen dramatic improvements in the capabilities of computer systems to recognize images, to segment images, to identify interesting bits of images, purely from learning from large labeled data sets. So if you look at the Stanford ImageNet Challenge, which is a computer vision contest hosted every year, in 2011, the winner did not use a technique called deep neural networks. And that was the last year that the winner did not do that, and they got 26% error on this challenge. And then every year after that, people have used deep neural networks and machine learning approaches based on those to get better and better results. And we're now down at around 3% error for the winner in 2016, which is just a fundamental shift in how you think about computers being able to see things. They basically couldn't see before in 2011. Now we can actually see. And human error on this task is about 5%. And translation has improved dramatically. More computational power has really helped these methods so that we can use these approaches on larger data sets, get results more quickly, and so on. And we've actually taken these advances and then put them to use both by writing research papers that advance the state of the art of machine learning, but also putting them into our products that are used by billions of people. So it's more than just writing papers. We actually use the results here. So now in Google Photos, for example, we can actually understand these are your pictures of mountains. So if you search for mountains, we can find you your photos of those. In Gmail, we can help suggest replies to emails you might have received based on the contents of the message. Can you come over for dinner? Sure, we'd love to. What can we bring? Or sorry, we can't make it. These kinds of things. And so when we looked around at what other areas were now potentially tractable for some of these kinds of approaches, lots and lots of problems in healthcare sort of struck us as amenable to these sorts of techniques. And so I'll just give you a brief tour of some of the areas that we're working on and just give you some results that have happened. So I'm going to classify them into three different areas. One is discoveries in basic sciences. Another is improving care and efficiency of delivery of healthcare, primarily in healthcare systems. And then scaling specialist expertise to make it more accessible. I'll just give one example of discoveries in the basic sciences. The cost of genomic data has dropped dramatically. The cost of sequencing a human genome now is a few $100s, whereas it used to be tens of thousands or even millions of dollars for the first few genomes that we sequenced. And that has led to this explosion of genomic data. And one of the reasons these advances have happened is that the modern generation sequencers break things into very short sequences of base pairs, 30, 50, or 100 base pairs, and fragment the genome, and then you get raw read data off these sequencers, and now you have to align it and then try to reconstruct the contents of the entire genome from these short 100 genome fragments. And it turns out if you do this, you can recast this approach as a deep learning problem. So if you kind of take all the different reads that overlap a particular area and pile them up as an image, as you see on the right here, then what you find is that you can very quickly see that there's different visual characteristics of different kinds of things that you want to understand in the raw data. For example, the top thing has an actual mutation at a particular position, whereas the bottom thing is caused by sequencing errors, where every time you read one of these base pairs, you have a very tiny chance of reading the wrong letter. And those look very visually distinct, and these deep learning models are actually able to pick up on these distinctions and do a better job of variant calling than other approaches that sort of try to hand analyze this with more simpler statistical methods. And what you see is that it actually works quite well. So this is sort of the total errors, false positives and false negatives, for a variety of different approaches. The two on the left are the earlier, more traditional kind of statistical-based approaches, and the two on the right are various forms of the deep variant algorithm. And obviously, since this is the very first stage in genomic processing, having fewer errors here means that all downstream uses of genomic data will be improved if we can reduce the sort of errors at this stage. And one of the things you see is that the error rate is actually going down as we improve the software. And the other nice property that this approach has is it's very amenable to training on different sequencing machines. Before, the statistical models were very calibrated to the exact model of the sequencing machine. But this, you can just retrain the data with new data coming off a different kind of sequencing machine and get good results. OK. So one of the great explosions in the last decade is that most healthcare records, in the US at least, are now in electronic form. And that presents a great opportunity. I think we've sort of underutilized the data that is in medical records to help us make better care decisions. So could we use machine learning to analyze the entire medical record and get useful insights from it? And there are a bunch of kind of clinical models that people put in practice for various things, predicting mortality risk, predicting the risk of sepsis, these kinds of things. And most of those variables are actually quite simple. They use very simple, small number of variables that are often sort of high-level summary features extracted from a patient's state, and then a very simple kind of statistical model. But if you look at the actual raw medical record data, most medical records have 100,000, 150,000, 200,000 data points, including textual notes, other kinds of things. So could we use all that data to make better decisions? And we published this paper at the very beginning of 2018. And there were two major insights. First, if you take all the data in the medical record and you essentially line it up on a timeline, including all the notes, the lab results, we ordered these labs at 3 a.m., 7 a.m., we got the lab results back, and the score for this was 73, and we got a 54 for some other thing, and you treat that as a longitudinal sequence. That gives you this really nice, rich longitudinal record. And then you can apply deep learning techniques that are really good at sequential processing of long time series of data. And that can also handle things like the clinician's raw notes, things like that. So in collaboration with actually Stanford, UCSF, and University of Chicago researchers at those medical institutions, we tried this approach on different collections of de-identified medical records. And what we found is that essentially you get all this raw data, and you can use that data for doing this. Each dot is a FIRE resource, and then you can predict a bunch of interesting things with the same underlying model architecture. So you can predict things like, what is the length of stay of this patient that's checking into the hospital? What is the likely length of stay? Do they need a particular kind of nursing facility? Are they likely to be readmitted if I allow them to check out of the hospital now? Are they likely to develop diabetes in the next 12 months? So kind of population health kinds of questions. And we came up with several different model architectures. The details aren't important. The second one is interesting in that it mentions attention, so I'll come back to that in a moment. But these approaches actually work quite well. And so, for example, for a bunch of different kinds of categories of things you care about predicting, for example, you might want to predict risk of mortality. If you have a better prediction of the risk of mortality, that enables clinicians to really focus their medical attention on the patients who are most at risk. And really, if you have more advanced warning of that, clinicians can focus their attention in appropriate manners. Things like resource utilization metrics, like length of stay, you can actually predict better, standard readmissions, and so on. One thing you can actually do that's kind of interesting, we haven't been able to find current clinical models that do this, is you can take all the data for a patient up to the point at which they're being discharged, and then these models can actually predict all the discharge codes for the patient with fairly high accuracy, which is good because you'd expect all that information to be there in some form in the medical record. And one of the things, I mentioned this model that uses attention. So obviously, one of the things that will help is if these models can be more interpretable to clinicians. So, and one of the techniques we use is a system that uses attention so that it can show you what part of the medical record it's paying attention to when it's making a prediction of a particular kind of thing. And here, what you see is that this is a patient that the existing clinical model predicted to have fairly low risk of mortality, but this model predicted fairly high risk of mortality. And it picked up on this term PLEURX, which my medical colleagues tell me is a particular kind of catheter that you insert for a sort of incurable catheter issue. It's a sign that you're basically very near your end of life. And we're able to actually show that the model can pick up on this and show you why it's predicting a high risk of mortality. OK. Another thing that we would like to be able to do is to use machine learning to take the skills that the world's best experts in particular areas have and make those skills more accessible to people all around the world. And I will give you a couple of examples. One is in the area of diabetic retinopathy. So diabetic retinopathy is a degenerative eye disease where if you have diabetes, you really should be screened every year for this disease. And if you catch it in time, it's very treatable. But if you don't, you can suffer full or partial vision loss before you actually get treated. It's the fastest growing cause of preventable blindness in the world, and screening can prevent this blindness. But it's very specialized. You need very specialized training, an ophthalmologist level of training at least. And for example, in India, there's a shortage of more than 100,000 eye doctors, and therefore 45% of patients lose vision before diagnosis. And this is incredibly tragic because it's entirely preventable if we were able to screen people at the appropriate frequency. And so it turns out the computer vision models we're using to detect something a mountain or a German Shepherd, you can actually collect training data of retinal images and then opinions of ophthalmologists of whether that is, a 1, 2, 3, 4, or 5 on this 5-point scale, and assess using the same underlying model architecture trained on retinal images, give a grade of 1, 2, 3, 4, 5 to a new retinal image. And this turns out to work actually reasonably well. So if you get every image labeled by a number of ophthalmologists and use the average score to train the model, you actually get a model that is basically as accurate, slightly more accurate than the average US board-certified ophthalmologist at this task. And it's something that can now run on a computer and do 50 or 100 images per second on a desktop computer with a GPU card. And in parallel with this, we're also extending to other eye diseases and other modalities of data. So our colleagues at DeepMind are using OCT, sort of 3D imaging of retinas to assess about 50 other eye diseases in this article published in Nature Medicine. And we want to do more than just publish papers. So we're actually have this system deployed in a network of Indian eye hospitals. We're actually working with the Ministry of Health in Thailand and are doing clinical trials in Thailand using this approach to treat patients in Thailand or diagnose patients. OK. Radiology and lung cancer screening is another important area. So if lung cancer is sort of the leading cause of cancer death in the world. So it's a really serious problem. And we know that if you are able to detect cancer earlier, lung cancer earlier, patients' chances of survival go up dramatically, 5 times higher than if you detect it in late-stage cancer. But screening is really hard because the only effective screening technique is with computer CT scans. And these create hundreds of images. It's sort of a volume of images for radiologists to review. And early-stage cancers are really, really subtle in that they often are very small. they're only showing up on one of these hundreds of images, and radiologists can sometimes miss these screens, these early signs of cancer. So in work published on Monday, we've been able to show that we can outperform the average radiologist at detecting these cancers, particularly for earlier stage cancers. And there you see the ROC curve. It's better to be in the upper left of those graphs. So farther up and to the left is good. And there you see the comparison to individual readers rather than just the averages you see on the right, on the left. So let's look at what this looks like on a single case. If we can roll the video. Yeah, so this is the initial scan, and it turns out in this particular patient, they had an early stage cancer that was missed by the radiologist. And then they came back a year later and found a fairly late stage cancer that the radiologist did detect. And here's the initial scan with this algorithm, which highlights a very subtle thing that is obviously very easy to miss on this particular case. And so that, I think, is the real promise. You could offer lung cancer screening as a sort of general protocol and try to detect lung cancer screens earlier. Pathology is another example of things that are going well, basically because medical imaging, computer vision has made such strides. All of these areas are sort of showing great promise. So diagnosis in pathology is obviously hard. There's both the problem of underdiagnosis and overdiagnosis. And basically, these images in pathology are actually very high resolution, so they're 100,000 by 100,000 pixels. And you're looking for essentially a needle in that very large haystack. And what we found is that training a model on images where pathologists have actually circled particular malignancies in those images, you can actually train models and actually find that the model outperforms pathologists given unlimited time, and given more time constraints as pathologists normally face, it significantly outperforms it. And we've built a prototype of this system that uses this model in real time on a conventional microscope. So as you move the slide around on the stage, it can actually, using mirrors, get access to the image that the pathologist is seeing, and then overlay an image of showing particular interesting points that the pathologist should pay attention to. And this is important because most of the world is still using conventional microscopes rather than digital pathology. And we're doing a bunch of other things. I'm not going to have time to go into them. One thing we've been examining is how well do sort of machine learning-based systems and conventional sort of pathologists interact and work together to make decisions. And what we found on this paper on the left is that pathologists take less time to make more correct decisions when they're paired with a system that is giving them kind of what you saw in the microscope, visual guidance of what things are interesting to look at and so on. And they also feel like the cases are easier to evaluate, so they're less stressed about it. Deep learning can help with drug discovery. We have a system that can dramatically accelerate by about 300,000 times the ability of computers to do simulations of what happens when you have these two molecules. Do they bind together or not? It can help with radiotherapy planning using different kinds of machine learning models. OK, so a few lessons of things that we've learned along the way. First, it's really important to pay attention to how messy the real world is. And I'll draw attention to this chart from the diabetic retinopathy work. So each row here is a patient image, one of those retinal images. And each column here is a different ophthalmologist grading those images with colors of the grade that they assigned. So if everything was consistent, you'd expect a uniform color on each row. And what you see is obviously, I don't need to tell this to this audience, opinions vary across different physicians. And in fact, the agreement between two different ophthalmologists grading the same image is 60%. on this score, 1, 2, 3, 4, 5. Slightly more worrying, though, is that the agreement between the same ophthalmologist grading the same image a few hours later is only 65%, which is slightly terrifying because the difference between a 2 and a 3 is like, go away and come back in a year versus we better get you into the clinic Monday morning. And so we had every image in that study graded by 7 ophthalmologists in order to reduce the variance in the labeled images. One thing we wanted to do, though, is actually make even better models. And so we both found that we could get retinal specialists who were more accurate at assessing this because they have extra training in assessing diabetic retinopathy, but also changed the protocol by which we label the training data. So instead of getting a bunch of independent assessments by retinal specialists or ophthalmologists, we instead sort of lock them in a room and say, okay, you 3 retinal specialists need to come to an agreement of what score you think this image should have. And with an adjudicated protocol using 3 retinal specialists, we actually found that we could then train the model, same sort of underlying model architecture, on this better labeled training data, and get a model that is now on par with retinal specialists, which are much rarer in the world. So you'd like sort of the gold standard of care. You'd like that expertise to be used everywhere. And with this approach, we found that we can actually sort of get a model that is on par with retinal specialists at doing this task. Ewan actually touched on this. Often you're training on data that is representative of the world as it is, not necessarily the world as you'd like it to be. And so we've done some amount of work in this. This is not a solved problem, but how can you, for example, change machine learning algorithms to take account of some kinds of biases that are present in the raw data that you're training on? So we have an article there, Ensuring Fairness in Machine Learning to Advance Health Equity. Another interesting thing is in the third article there, when that paper was submitted, they suggested that that perhaps the data set was not representative of other data sets of retinal images. And so they asked the authors of the paper to evaluate it on a completely different data set. I think the original was using North American retinal images from a US healthcare system, and they asked them to evaluate it on a Thai data set of retinal images. And what they found was that the results there transferred quite well. So there wasn't any sort of worry about that. But it was a nice thing that the review process sort of injected that extra scrutiny. OK. And the other thing that's kind of interesting is we're now, all the things I've told you are things that clinicians already do. But what if we told you that you could see new kinds of information using a machine learning model in things like retinal images? So in particular, one thing we've found that we're able to do is predict cardiovascular risk from a retinal image to the same level of accuracy that you would normally get with a more invasive blood test. So you draw blood, send it off to the lab, 24 hours, you'd get results back. Instead, we can get that same level of cardiovascular risk assessment from a retinal image. And this is sort of interesting because if you ask an ophthalmologist to do this, one of the things you'd like, one of the subcomponents of this that you'd like to predict, this is sort of came about from a bit of a science experiment. Someone new joined the team, and in order to help them figure out how to use this training software pipeline, the leader of the team, Lily Peng, said, oh, why don't you try to predict a self-reported sex from this data set where we actually have retinal images and sex and age. And since ophthalmologists can't do this, she thought the AUC on this task should be 0.5, but at least they'd be able to train a model from end to end. And so they went away, and a few days later they came back, and the AUC that they reported was 0.7. And Lily said, no, that can't be right. Go check everything and come back. And so they came back, and they said, I've fiddled with a few things, and now it's 0.8. And so that got people thinking, what could we see in a retinal image that perhaps we didn't know we could see? And if you ask an ophthalmologist to do this, they're like, I don't know, like it's no better than flipping a coin, basically. And so I think this is the real potential, is are there signals and signs that we, as humans, can't see because we've only seen, 5,000, 10,000 images, retinal images in our lifetime, but in 100,000 or 1 million, maybe we could see more. And maybe you'll start to collect retinal images as part of your longitudinal health record. Another example is predicting stains. So normally when you're doing microscopy and you want to stain something, you actually put physical stain on the slide, and that often kills whatever you're trying to look at. But what we've been able to do is train a model that can predict the effects of stain without actually staining it. And so that allows you to get longitudinal kind of time series things of, how does this thing develop over time? And that's pretty nice as well. OK, so this is a rather broad summary of a bunch of work. We're doing lots of other things in this space, but we really think that there's real potential for AI to make new things feasible. And in particular in healthcare, the potential exists to improve the health of billions of people. Can we use all the collected human decision-making in healthcare to improve the next healthcare decision that is made by a doctor or a clinician? So that's what I'm excited about. And I think Nigam and I are now going to chat.
All right. So thank you for that sweeping tour of all of the work that you're up to. So we can sit down, and I'll kick off with a couple of questions. Being able to classify and predict is kind of a given. I mean, Google and many other companies, they've just demonstrated that hands down. How do you see us going into the clinic with these models and impacting workflows that improve care? What are your thoughts around the right modalities to experiment with that?
Yeah, so I think, for some things like a diagnostic tool, it's relatively simple because you can sort of say, OK, I have a radiology image, and there's a radiologist who's going to look at that. One very simple way to inject that is to say, let's just give the radiologist access to an instant second opinion or sort of visual highlights about what the model thinks are interesting bits of the radiological data to look at. For other things like the medical records prediction task, I think there's many, many different ways to use that. So for example, if you have a patient sitting in front of you, what are the 5 most likely diagnoses that might make sense for this? And then I think it might be that 98% chance it's the thing the clinician is thinking about themselves. Might be the second thing is a 1% chance of this rare thing that individual clinician has never actually encountered at all. And at that point, I think you then want tools that enable the clinician to go off and investigate, other similar cases, find out more about, like, what if I treat it this way? What does that do to the likelihood of them coming back to the hospital in the next week versus this other, alternative treatment? And so I think it's going to be a more interactive tool for some of these kinds of deployments, and I think that's interesting and has UI challenges and all kinds of things.
All right. Well, thank you. I'll do one more question. A lot of these, the training of these algorithms requires massive amounts of label training data, and up till now, because it's all experimental, we have 7 experts and 5 experts labeling things. What are your thoughts on how can we, as a discipline, get a cheaper source of labels?
Yeah, I think one of the things is that if you look at the totality of medical data in the world, there actually is a lot of labeled medical data from past patient histories and so on. And I think there's very real privacy concerns about how do you actually make use of that data. But for example, we've developed a technique called federated learning, which is what we use to train models on hundreds of millions of phones so that when new words come into existence in the vocabulary, the sort of vernacular of modern society, you don't have to type that new word on your keyboard in order for your keyboard to get smarter about it. But we don't want to send the raw keystrokes of everyone to a centralized location to train these models. So instead, we can train models collectively on the typing on all these hundreds of millions of phones in order to actually improve the model for everyone. And we ship the model parameters, but not any of the raw data. And so I think that kind of approach in healthcare systems could be, or even across healthcare systems, could be an interesting approach to getting more data for these problems.
Fascinating. We'll open it up to audience questions. There's a couple of microphones, I think 2 in both aisles. And while you formulate your question, please come up to the microphone. Actually, I already saw one hand up. I'll ask one sort of final question before we have somebody at the microphones. Okay. in healthcare, there's this known fact that there's a huge skew in the cost, in the sense that a very small fraction of people are responsible or result in a lot of resources needed for their care. How do you see the use of AI help balance out the cost of care?
Right. I mean, I think the right way to view this is the goal should be how can we get everyone healthier, right? And if you take the people who are currently like very, very sick and consuming a large healthcare burden on the costs side, if you get them a little bit healthier, their costs will go down dramatically. And if you get people who are sort of in that intermediate band healthier, they themselves will consume less costs. So I think moving everyone a level up in terms of healthiness through behavioral change, other kinds of things, is probably the most likely way to reduce costs.
All right. And I think we have a first question here.
Hello, it's Barbara Roth, Vienna Vaccine Safety Initiative. I just had a question. How do you grapple with the data that we physicians never capture? I think the biggest bias is our own view of our patients and the preconceived notion of what we expect to find.
Yeah. So obviously, I think if we can, the medical record, as an example, is a very weak summary of what has actually transpired in the treatment of a patient, right? You've had a lengthy conversation with a patient, and that gets digested into a 20-word note. And I think that is a problem, right? Like if we could capture richer data about these interactions and decision-making processes, that would be good. But on the other hand, clinicians currently really don't like interacting with the medical record system because it's painful even to get that 20-word note and all the codes you need to fill in and whatever. And so I think AI and machine learning can really help here as well. So one of the experiments we're doing is, can we have a system that listens in on a conversation between a doctor and a patient with consent, and then can give you a transcript of what has occurred, and then give you a draft of the medical note that you might like to put in there, and also perhaps give the patient a summary of the conversation in maybe different language than what the clinician would use in the medical note. I think that's where we could go, because then you actually have the raw data in richer form if you need it, but you also reduce the burden of clinicians to spend a lot of time after hours typing medical notes into the medical record system.
All right, we'll go to the question in the back.
I'm just a reaction to that. I think it would be absolutely brilliant if Google could fix the electronic medical record problem. That would be a huge contribution. Obviously, I come from the medical side, not the tech side. So this may seem like a naive comment, but it seems to me that there are areas where precision matters a great deal, and there are areas where sort of general forecasting is okay. Like, and I mean no offense by this, but Google knows that I'm really passionate about luggage and penguins, but it still thinks that I'm a 70-year-old man, and I get some really weird prostate ads as a consequence. and that really doesn't matter because I can ignore that. Right. But similarly in medicine, there are going to be some areas where precision is really important, such as the retinopathy prediction, and then some other areas where you can afford to be kind of, slightly hand-waving in the general direction. And it seems to me that that must present a very big challenge when it comes to what you referred to in the beginning, integrating very large numbers of data points that span the lifespan and all types of patients and all comers. And maybe you could talk more about how you target that, or how you refine the goals of what really matters.
Sure. So in the medical records work, for example, that is you training a single model with a large capacity to remember key aspects of many de-identified medical records that it was trained on. But we don't train a separate model for a 77-year-old man versus it's one large model. I think the more general point, though, is that many of the decisions we're making in medicine and healthcare are much more consequential than what ad should we show you. And so that means that the way in which these models are actually put into practice has to be much more thoughtful and careful and methodical as kind of, as is appropriate. And so most of what we're doing initially is how can we give instant second opinions to existing clinicians in the way in which they're already accustomed to working. so that they can, get a quick oversight of maybe they missed something and this system picked up on something that they missed, rather than sort of replacing what they're doing with a machine learning algorithm by itself.
All right. Oh, we'll go to Marza here.
Hi. My question is, at the beginning, you noted that one of the reasons that computer vision has really made fantastic advances is that we have these large open data sets that people all over the world can benchmark their latest machine learning algorithm on. It's what we make all our students do, right, every year. How is Google going to help move the progress of research in this space forward with data sets that are currently not available to most researchers?
Yeah, I mean, I think the problem of accessibility for medical data for open research is actually a pretty significant one because, often it's the patient's data at heart. And I think one way we could make progress is to encourage patients to share aspects of their medical records for research purposes with their consent. At the moment, medical researchers can sometimes get access to de-identified or anonymized versions of data sets, but that's a bit haphazard, and it often means that people are working on different data sets for similar kinds of approaches to solving problems, and then you can't really compare the results. So I agree with you, it would be nice if there were more standardized data sets. So for example, the medical record space, there's a relatively small one called Mimic that is used for all kinds of medical records research, but it's really small enough that it isn't necessarily representative of what real world sort of healthcare system medical record data sets look like. But, I think there's no easy answer here because the data is much more sensitive than a bunch of pictures of cats and dogs.
So I'm going to jump in as moderator just a little bit. There's the availability issue, and then there's also the trust issue. In healthcare, there's been numerous polls that show that as an individual, we don't trust the government with our data, we don't trust insurance companies with our data, we don't trust the tech companies with our data, we don't trust our hospitals with our data, but then we still want to benefit from the application of machine learning. So that's a really problematic catch-22, and I'm sure you've spent a lot of time thinking about this, so would you share your thoughts about that?
Yeah, I mean, privacy in healthcare data is a very, very broad-ranging and complex topic, and regulatory issues that span countries and so on also are complex in this space. So I think if you set that aside, the opportunity in front of us, if we can figure out how best to do it in a way that has appropriate privacy guarantees, is we would like every healthcare decision that's been made in the past to be used to inform future healthcare decisions, right? That's like a good aspirational goal. And how can we find ways to make that as close to possible as we can? And things like federated learning, things like maybe automated ways of de-identifying or anonymizing data sets, things like this can push in that direction. But it's definitely a challenging problem.
All right, I think this aisle back and then over here.
Partha Bhattacharya, National Institute on Aging. So I have a question which delves into the data. It's a follow-up on the data question. How do we deal with integrating AI or machine learning approaches in clinical care when we do not have all the data? It's missing data, right? And what do we need to do to take advantage of the promises of AI to make clinical care better?
Yeah, I mean, I think one thing is that right now, different modalities of data are sort of treated separately in the care of patients, right? There's a separate PACS system for certain kinds of medical imaging. There's a medical record system. There's the patient's own fitness sensor data if they use a Fitbit or whatever. And ideally, you'd like to have all this data come together at the point of care so that with patient permission and other appropriate permissions, clinicians can look at the complexity of data that is associated with that patient and other similar patients in order to make decisions. And for any given patient, they may not own a Fitbit sensor, but some of them will, some of them won't. And you'd like to be able to make use of that. And you need to be able to figure out how to train machine learning models that can deal with heavily multimodal data like you see in medical settings.
All right, I think question over here.
First of all, wonderful talk. It was a great tour. Question is related to, I'll come back to the earlier remark about the goodness of the ground truth, and also to your remark during the talk about how the same diagnostician asked the same question twice gives a different answer, which we have seen many times before.
Yeah.
Have you considered, or has anybody tried to work on understanding what is the source of that variation, and is there a way to learn that and to mitigate the variation rather than trying to say, let's throw that away and then fix the end goal?
That's a great question.
I mean, I think the source of variation is really, at least in the diabetic retinopathy diagnosis issue, is just that the difference between a 2 and a 3 is not a crisply defined thing. It's sort of like, how dark do you think those hemorrhage-looking spots are, and how big are they? And it's not as well defined as you might like. And so that's why one person can stare at it and say it's a 2, and the next person can stare at it and say, no, I think it's more like a 3. And I think that's just inherent in the problem. It's not that things go from a crisply defined 2 to suddenly becoming a crisply defined 3. It's sort of shades of gray. I think we just need to accept the fact that the real world is messy, and that some of these opinions are a bit noisy. Machine learning algorithms are actually reasonably well suited at dealing with noisy data. As you see, if you get sort of multiple independent opinions, you can actually train an algorithm that is going to be better than any of those individual ophthalmologists doing that task.
All right, the monitor here is indicating that we need to wrap this session up. So join me in thanking Jeff one more time for this fabulous tour.
Thank you.